session, I will be discussing edema. What is edema? Pathogenesis of edema and what are the types of edema? Let's start edema. So what is edema? How you will define edema? So edema is defined as it is the abnormal and excessive accumulation of fluid in the interstitial tissue space. So it is simply, in layman's language, it is known as swelling. So here in this diagram, you can see a typical diagram of a pitting edema. And in this diagram, you can see these are the cells of any organ. You can consider it at any organ of human body. It can be brain, it can be kidney, it can be liver, it can be spleen, any organ of human body. All organ of human body are made up of cell. So you can see various cells in this organ. You can see the blood supply of this organ. This is the blood supply. Now the space between the organs is known as interstitial. Between the cells of the organ is known as interstitial space. Can you appreciate this space I'm marking? Can you appreciate this space? The space between the cell. This is known as interstitial space. Normally this space is dry. There is no fluid in this space is dry. But whenever there is abnormal and excessive accumulation of fluid in this space, it is known as edema. So edema is defined as pathologically, that is abnormal and excessive accumulation of fluid in interstitial space. You can appreciate interstitial space in this diagram. This is edema, and in layman's language it is known as swelling. So that is the definition of edema we give: abnormal and excessive accumulation of fluid in the interstitial space. There is one more related term. It is known as effusion. It is related to edema only. So effusion is abnormal and excessive accumulation of fluid in the body cavities, not in interstitial space. In human body, we have various cavities. We have pleural cavity around the lung. We have pericardial cavity around the heart. So if abnormal and excessive accumulation of fluid occurs either in pericardial cavity or in pleural cavity or in peritoneal cavity, any cavity of human body, it is known as effusion. So we have to understand two terms, edema and effusion. So definition of both of them is abnormal and excessive accumulation of fluid. So abnormal and excessive accumulation of fluid, if it occurs in the interstitial space, that is the space between the cell, it is known as edema. And if abnormal and excessive accumulation of fluid occurs in body cavities, it is known as effusion. So these are the two terms. We will understand both of them because the pathogenesis of both of them is same. So let's start the pathogenesis of edema and effusion. But to understand the pathogenesis of edema and effusion, you must know normal tissue exchange. For explaining you normal tissue exchange, there are various pressures which will come in the role. So let me draw a diagram for you. Here I will draw a diagram. In this diagram, you can see there is an artery. For every organ, the blood supply of the organ, there is an artery. From the artery, multiple capillaries arise. And capillaries will give rise to venules, and venules carry the impure blood to the right side of the heart. So let me draw the blood supply of an organ. Let me draw an organ, the organs, the cells of the organ. Can you see I am drawing the cells of the organ? These are the cells of any organ of human body. Let me draw its blood supply. So this is the artery. Artery gives rise to capillary. So this is the capillary. And capillary gives rise to the vein. So this is a vein. So here in this diagram, you can see this is artery. This is capillary, this is vein. In this diagram, you can appreciate the capillary. Now, in the capillary, we have two ends. This end of the capillary is known as arterial end of the capillary, and this end of the capillary is known as venous end of the capillary. So, capillary have two ends. Now, let me explain the two type of pressures which are taking role here. So, there are two types of pressure in the capillary of human. The hydrostatic pressure, the oncotic pressure. What do you mean by hydrostatic and oncotic pressure? Hydrostatic pressure is the pressure which is caused by water in the blood, and it is always outward. It is always outward pressure. And osmotic pressure is the pressure which is due to protein content of the blood. It is always inward. So at arterial end also we have hydrostatic and osmotic pressure. One is outward, one is inward. The hydrostatic is due to water, it's outward, and osmotic is due to protein, it is inward. At the venous end of the capillary also we have hydrostatic pressure and osmotic pressure. Let me tell you the values of these pressure. So we will apply the physics here, that is which is outward, which is inward, what is the net pressure at arterial end of capillary, is it outward or inward? What is the net pressure at venous end of the capillary, is it outward or inward? And then we will understand the mechanism, normal fluid exchange. So you can understand here, osmotic pressure is always 25. It is always 25 mm. It is always 25 mm, whether it is arterial end of the capillary or whether it is venous end of the capillary, the protein content doesn't change. Since protein content doesn't change, osmotic or oncotic pressure, one and the same thing, these are synonyms. So osmotic and oncotic pressure doesn't change. The value always remains 25 mm. So that is about osmotic or oncotic pressure. But what about hydrostatic pressure, which is outward pressure? So at arterial end of the capillary, the hydrostatic pressure, it is 38 mm. 38 mm. But at venous end of the capillary, it is only 12 mm. At arterial end of the capillary, there is more water, more hydrostatic pressure. And at venous end, there is less water, less hydrostatic pressure. So the value differs. Now see the net pressure. I'm talking about net pressure. So what is the net pressure at arterial end? At arterial end, the hydrostatic pressure is 38. But oncotic pressure is 25. So of course 38 is more than 25. 38 minus 25, it will be 13. On subtraction, we are getting the value of 13 mm. But this 13 mm is outward or inward. So we are seeing the two values. Hydrostatic pressure is 38, which is more than osmotic pressure, which is 25 mm. The unit of the pressure here is mm. So outward pressure is more than inward. So the net 13 is outward. At arterial end, it is outward. Coming on venous end. In the venous end, you can see the two pressures. So a hydrostatic pressure is only 12, but osmotic pressure is 25 mm. So you can see 25 is of course more than 12. 25 minus 12, the answer is again 13. But this time osmotic pressure is more than hydrostatic. That is inward pressure is more than outward. So this net 13 mm is inward. You got my point? So what is actually happening when blood is entering a capillary? So the arterial end of the capillary will come. So arterial end of the capillary net pressure is 13 mm outward. Right. So fluid comes out because the net pressure is outward. So fluid comes out here. The fluid comes out here. The fluid is coming out and getting accumulated here in the interstitial space between the cells. The fluid is coming out by 13 mm of pressure, which is the net outward pressure. So this fluid is pure, containing oxygen and nutrients. So that's exchange will take place. So cell will take the oxygen, give the carbon dioxide, cell will take the nutrition, give the vestigial material. So the fluid is pure and after some time it will convert into impure. Now at the venous end of the capillary, again we have net 13 mm of pressure, but this 13 mm is inward. So whatever the fluid after exchange, it will go again inside the capillary at the venous end. So basically, whenever the blood passing in a capillary at arterial end, the fluid is coming out by 13 mm, does the necessary exchange. At venous end, the same fluid goes back in the capillary with the same pressure, 13 mm inward pressure after exchange. So fluid is just coming out to do the exchange. At arterial end of the capillary, it is coming out, and after doing exchange at venous end of the capillary, it is going back. So in the interstitial space in a normal healthy human being, there is no fluid and interstitial space is dry. There is no fluid in the interstitial space. Interstitial space is dry. Normal healthy human beings don't have edema. So this is, if you understand the normal fluid exchange, then it will be very easy for you to understand the pathogenesis of edema. So you got it, I guess. Yes. So at the there is a capillary. There are two ends, arterial and venous end. At the arterial end of the capillary, the blood is entering from the artery. So this blood is pure blood containing oxygen, containing nutrients. So at arterial end, if we apply the two pressure, hydrostatic and osmotic. So hydrostatic is more than osmotic. So net pressure is outward. Outward is more than inward. So net is 13 mm outward. So whenever the fluid, the blood enters the arterial end of the capillary with the 13 mm of pressure, the fluid comes out. So it will spread in the interstitial space and do the exchange with the cell. So whatever oxygen and nutrient present in the fluid will enter inside the cell, and whatever carbon dioxide and vestigial material present inside the cell will come out in the fluid. After exchange, now let's talk about the venous end of the capillary. At the venous end of the capillary, again we will apply the two pressures, hydrostatic and osmotic. Here hydrostatic pressure is only 12 mm and osmotic pressure is 25 mm. So of course osmotic is more than hydrostatic, 25 is more than 12, that is inward is more than outward. So 25 minus 12, again it is 13 mm, but the value is same, but this time the direction is, it is inward pressure. So after exchange the fluid goes back. So this is a beautiful mechanism taking place in human body every moment, whether we are aware of it or unaware of it. Inside human body, inside a healthy human body, the complete mechanism always takes place. At each and every moment, the physics is applied and these pressure changes are like this. So there is a balance. At the arterial end of the capillary, it is 13 mm outward. At the venous end of the capillary, it is 13 mm inward. So there is a balance. of the outward and inward pressure. That's why whatever fluid coming out by 13, the same fluid goes back by 13 mm. 13 outward mm, 13 inward mm at arterial and venous end. So tissue remains dry. In the interstitial space, normally there is no edema. There is no edema. So that is the complete physics, the mechanics behind the normal tissue exchange, and this is all known as Starling's law. And if any minor changes occur, just suppose instead of 13 at arterial end there is 14 mm, but at venous end there is 13 or 12 mm. If any minor pressure changes occur, still there is a backup. There is a backup in human body. The backup is known as lymphatics. So lymphatics are present everywhere. The lymphatics takes the extra fluid. So normally the pressures are equal and opposite. At arterial and venous end they are equal, that is 13 mm, 13 mm, and they are opposite. At arterial end the direction is outward, at venous end the direction is inward. So normally tissue remains dry. Even if small pressure changes taking place, because of which a little bit edema is there. So for the backup, lymphatics are always there. It takes the extra fluid and the tissue remains dry. So this is normal. If you have understood normal, now it will be easy for you to understand the pathogenesis of edema. To understand the pathogenesis of edema, you can understand if the interstitial space, the fluid has to be accumulated. Two of the things are required, either increase outward pressure or decrease inward pressure. Because of them, the fluid will come out more but go back less. So it will be accumulated in the interstitial space. So either increase in hydrostatic pressure or decrease in osmotic pressure, or third is the lymphatic obstruction. These are the three main causes of edema, apart from which two more are there: sodium water retention and inflammation. So total 5 causes of edema are there. Now whatever I have explained you on this slide, I will show you how to write in the exam in theory. So you can see the same diagram here which I have drawn for you from a book. You can see the arterial end, you can see the venous end. At the arterial end you can appreciate the hydrostatic and osmotic pressure. Please appreciate the values. Hydrostatic is 38 and osmotic is 25. At the venous end of the capillary, again a hydrostatic and osmotic pressure, appreciate the values. Osmotic is same, it is 25 here also, 25 here also, but hydrostatic pressure is different. At arterial end it is 38, at venous end it is 12. So you can appreciate the tissue. This is the cells of the tissue. Appreciate the space between them. The space between them is the interstitial space. Now you can appreciate hydrostatic pressure is due to water and it is outward pressure. Osmotic pressure is due to protein and it is inward pressure. So this is outward pressure and this is inward pressure. These are the general rules you must know. So outward and inward pressure. The same diagram you can see in a longitudinal way. In this diagram also you can appreciate this is the blood vessel, this is the capillary. Okay, in this capillary this is the arteriolar end and this is the venular end in this capillary. At arteriolar end, please appreciate the value of hydrostatic pressure is 38 mm of mercury. At venous end, it is 12 mm of mercury, but osmotic pressure throughout it is 25. So see the difference here, it is 13 mm mercury but outward. See the difference here, it is 13 mm mercury but inward. So equal and opposite, and you can appreciate these are the cells of a tissue. Appreciate the space between them, so it is dry. So in the same diagram it is shown. So same values are written. You have to write the values in your exam like this. At arterial end of capillary, the hydrostatic pressure is 38. At venous end of capillary, the hydrostatic pressure value is 12 mm of mercury, but osmotic pressure throughout it is same, it is 25. Throughout it is 25. So the same diagram. So basically what is happening at the arterial end? What is the physics? Apply the physics at arterial end. Apply the physics at venous end. So let me apply one by one. At arterial end, it is 38 minus 25. That is 13 mm of mercury. So hydrostatic minus oncotic. This 13 mm is outward pressure, net outward. At venous end, it is 25 minus 12. So again, it is 13 mm of mercury. The net pressure is 13 mm. But this time, it is inward. This pressure net inward. So net outward, net inward. So there is a balance. I have explained you what is the balance. And even if small minor changes taking place, so lymphatics are there. So lymphatics will ultimately return it to the bloodstream. You can see in this diagram, these are the lymphatics. So whatever additional fluid is there in this space, that is taken by the lymphatic. So that is the thing. Till now, you understand what is edema. The definition of the edema, it is abnormal and excessive accumulation of fluid in the interstitial space. That is edema. You have understood the normal tissue exchange. In the normal tissue exchange, that is Starling's law, the two types of pressure, hydrostatic and osmotic. Hydrostatic is outward, osmotic is inward. Now apply the values of these two pressure at the arterial end of the capillary, and same these two pressure, apply the values at the venous end of the capillary. So see the net pressure, the value and the direction. So it is equal and opposite. The value is equal and the direction is opposite. That's why tissue remains dry. There is no edema. And for backup, there are lymphatics. Now coming on the pathogenesis of the edema, if fluids want to accumulate in the interstitial space. What is edema? Accumulation of fluid in the interstitial space. For this, one of the two things are required. Either outward pressure is more or inward is less. If outward pressure is more, so more fluid will come out. And if inward is less, less will go back. So coming out is more, but going back is less. So there is accumulation of fluid in the interstitial space. That is edema. So either increase hydrostatic pressure, that is the outward pressure, or decrease oncotic pressure, that is the inward pressure. So either increase outward, decrease inward. Outward pressure is hydrostatic pressure. So either increase hydrostatic pressure or inward pressure is oncotic pressure. So decrease oncotic pressure, that can lead to edema, or both of them occurring together, or one of them. The third major cause of edema is lymphatic obstruction. So due to the lymphatic obstruction also edema can occur. The third mechanism. Fourth is sodium water retention. Due to sodium water retention also edema can occur. And fifth and last is increased permeability. Increased permeability that occurs in inflammation. Now, I will explain you all these 5 mechanisms one by one with the examples of each of them. Let me take the first thing, that is increased outward pressure or increased hydrostatic pressure. As I have told you, hydrostatic pressure is outward pressure. So if outward is more than inward, so more fluid is coming out but not going back. So fluid will retain in the interstitial space and it can lead to edema. That is the mechanism. Coming on the examples, there are 2 examples of edema because of this cause, that is increased hydrostatic pressure. So first is cardiac edema, second is postural edema. I will explain you both in the form of the diagrams. See this diagram, it is a diagram of heart. In this diagram, you can understand, like, imagine the right heart failure. The right ventricle is not pumping, it is not doing systole. So blood is not going ahead in the lungs for purification. The right ventricle is not doing systole. So what will happen? Where the blood will go? Blood is not going forward, so it will move backward. So from right ventricle, the blood will go to right auricle. From right auricle, the blood will go to SVC, IVC. And from SVC, IVC, the blood will go in the veins of the organ. So veins of the organ contains more blood. Because of the backflow, it will be more blood. More blood means more water. More water means increased hydrostatic pressure. So because of the increased hydrostatic pressure inside these organs, the fluid will come out and that can lead to edema of the organ. So in right heart failure, that is cardiac failure, patient have edema of all the organs. This is known as anasarca. The reason behind that, the pathogenesis behind that is increased hydrostatic pressure. So the right ventricle is not pumping, so blood is not going forward, it is going backward, and via backward flow, the blood is reaching in the veins of all organ. So veins of all organ have more blood means more water means more hydrostatic pressure, and more hydrostatic pressure means outward more and inward is same. That can lead to retention of fluid in the interstitial space, and that is known as edema. So edema is, by this mechanism, it is right heart failure. The same mechanism can be applied on left heart failure. Now please imagine the left heart failure. In this diagram, the left ventricle is not pumping, blood is not ejected into the aorta. So there is no forward movement of the blood. So blood is going backward. Where the blood is going? The blood is going backward. So from left ventricle, it is going to left auricle. From left auricle, it is going to pulmonary vein. And from pulmonary vein, it is going to the lungs. And in the lungs, it is causing the edema. It is causing edema in the lungs. So more fluid, more blood, more water in the veins of the lung, that will increase hydrostatic pressure. So fluid will leak out and causing pulmonary edema. So in right, what is the summary? The summary of this diagram is that in right heart failure, edema occurs of all organ. In left heart failure, edema occurs of only lung, that is pulmonary edema. So that is cardiac edema, either right heart failure or left heart failure. In right heart failure, edema of all organs. In left heart failure, edema of only lungs. So ultimately, both of these edema, either in all organs or only in lungs. The mechanism is increased hydrostatic pressure because of the backward flow of the blood, more water, more hydrostatic pressure. So that is cardiac edema, the first example. Coming on second example, for explaining you second example, let me draw a human who is standing. See, I am drawing a rough diagram of a human being who is standing in standing position. In the legs, there are veins. Big veins are there, superficial and deep veins of the legs. So I am drawing veins in the legs. Now imagine a person whose profession or job is standing, like the traffic policeman. So traffic policeman job is standing for long hours. The person is standing for long hours. So because of the gravity, all the blood, out of 5 liters of blood in human body, most of the blood is pulled because of gravity in the legs. So legs, vein have more blood. More blood means more water means more hydrostatic pressure, and more hydrostatic pressure, the fluid will leak out. Osmotic pressure is same. but hydrostatic is more. So fluid is coming out more but going back less. So it will accumulate in the interstitial space and this person will have leg edema. The edema of the legs, the edema of the feet. And this edema is known as postural edema. It is due to the posture of this person who is standing for long hours. So it is known as postural edema. So the two examples of this is cardiac edema and postural edema, that is due to increased hydrostatic pressure. Coming on the second cause of edema, that is decreased oncotic pressure. Decreased plasma oncotic pressure, not increased hydrostatic pressure, decreased oncotic pressure. Now, decreased oncotic pressure means decreased inward pressure. Outward pressure is same, but inward pressure is less. So if outward is same and inward is less, so it can lead to edema. Fluid will come out normally but go back less. So it can lead to edema. The main protein which is causing oncotic pressure is albumin. I have told you oncotic pressure or osmotic pressure is the pressure due to proteins. So protein, the main protein in the blood is albumin. So due to any reason, if albumin in the blood is less, hypoalbuminemia, it will lead to decreased oncotic pressure. So due to any reason, if protein content of the blood is less than total protein content is up to 8 gram per deciliter. If it is less than 5 gram per deciliter, so that is hypoalbuminemia, it can lead to decreased oncotic pressure. So inward pressure is less but outward is more, so it can lead to edema. This is the pathogenesis. Now let me give you 3 examples of this. That is edema due to decreased oncotic pressure. For this, you have to understand this diagram. Can you see in this diagram, this is a blood vessel. So in the blood vessel, the protein is present. Can you see the protein? This one is protein. So from where, can you tell me the source of the protein? From where this protein comes in the blood? In the blood, from where the protein is coming? So whatever protein the person takes in the diet person is taking protein. So that is going in the esophagus, stomach and intestine. From the intestine, that protein is absorbed and reaching in the blood. So the first source of the protein is GIT, the dietary protein, number 1. Number 2, the liver also synthesizes protein. So second source of the protein in the blood is liver. You can see crystal clear in the diagram. The first source of protein in the blood is GIT. And second source of protein in the blood is liver. So normally kidney do not excrete protein. Whatever protein going to the kidney, it is not excreted, it will be retained in the blood. But if kidney is damaged in nephritic or nephrotic, especially nephrotic syndrome, if the kidney is damaged, so it will excrete the proteins in the urine. So urine will have protein that is known as albuminuria. It is known as proteinuria or albuminuria, that is protein in the urine. Now, what are the 3 causes? Can you tell me the 3 causes of decreased protein in the blood? I want to do decreased oncotic pressure. For decreased oncotic pressure, decreased protein. So there can be 3 reasons. Either person is eating less protein in the diet, ingesting less protein in the diet, or if the diet protein is normal but absorption, there is problem in the absorption. The intestine is not absorbing it. That is the first reason. That is, the problem is in the GIT, that is absorption is less. Number 1, either dietary is less or absorption is less, the first reason. Or liver is damaged. The liver is cirrhotic, alcoholic cirrhotic or other cirrhotic, and liver is not synthesizing the protein, the second reason. The third, GIT is normal, absorption is normal, liver is normal. All of them are synthesizing normal protein content in the blood, but kidney is damaged. So whatever protein present in the blood is excreted by the kidney. So there are 3 reasons for decreased oncotic pressure. Number 1, malabsorption. Number 2, liver failure, liver cirrhosis. And number 3, kidney failure, that is nephritic and nephrotic syndrome, renal failure. So these are the 3 examples in front of you. So either inadequate synthesis occurs in liver. Number 2, malnutrition. The patient is eating, the person is eating, but intestines are not normal. They are not normally absorbing it. And number 3, increased loss of albumin in the urine. That is in nephrotic syndrome. In nephrotic syndrome, these are the 3 reasons. Coming on the third reason of edema. Till now, we have discussed the 2 reasons of the edema. Increased hydrostatic pressure and decreased oncotic pressure. So increased hydrostatic pressure, there are 2 examples. Heart failure, right heart failure, left heart failure. And second example is postural edema. In decreased oncotic pressure, the second mechanism, we have understood 3 examples. Number 1, malabsorption from the intestine. Number 2, liver failure or liver cirrhosis. And number 3, renal failure, nephritic or nephrotic syndrome. Now coming on the third mechanism of edema. So now both the pressures are normal. That is, hydrostatic pressure, outward pressure is normal. Oncotic pressure, inward pressure is also normal. Still the patient is having edema. Now what is the cause of edema? Both the pressures are normal. You may wonder, ma'am, now why the patient is having edema this time since both the pressures are normal? The person can have lymphatic obstruction. Lymphatics are the backup. So due to the obstruction of the lymphatics, such edema is known as lymphedema. Lymphedema. Now what are the reasons? Can you see the lymphatic here? These are obstructed. There is obstruction in the lymphatic due to any reason. So it is the backup. Now the fluid is getting accumulated in the interstitial space. Lymphatics are not taking it again in the blood. So that can be the reason. There are 3 examples of edema due to lymphatics. Number 1, axillary lymph node removal while doing the surgery for the breast cancer. Number 2, elephantitis or filariasis. And number 3, Milroy disease. I will show you the 3 diagrams to explain you this. Can you see this diagram? Imagine this lady is having cancer in the breast. Can you see this is malignant cancer in the breast? Now we know carcinomas, it is a carcinoma spread by lymphatics. The regional lymphatics here is the axillary lymph nodes. Please appreciate. All these axillary lymph nodes, they can be involved in breast cancer. So this lady for treatment went to a surgeon. The surgeon operated the lady. So surgeon took the breast cancer out, the lump from the breast, either lumpectomy or mastectomy. So the lump present in the breast is surgically taken out. Number 1. The surgeon also take the lymphatics of the axilla if they are involved. So very commonly the lymphatics are also involved in case of breast cancer. So these lymphatics are also removed in surgery. So surgeon is doing 2 surgeries, 2 incisions will be given. One in the breast, removing the tumor from the breast. And second in the axilla, removing the axillary lymph nodes from the axilla. Now, this lady is not having axillary lymph node. What this will have? So after the surgery, she will have edema in that limb, and this edema is known as lymphedema. Can you appreciate this is lymphedema? Because it is due to the removal of axillary lymph node. If the surgeon don't remove axillary lymph node which are already involved, this lady will have metastasis very soon. So the tumor will spread and it can cause metastasis. So removing is very necessary. So you can say lymphoedema of that related arm is a morbidity of the surgery. It is unavoidable and it is the morbidity of this after the surgery. The second example is filariasis or elephantitis. In the leg, there are lymphatics. Now there is a parasite. The name of the parasite is Wucheria bancrofti or filarial parasite. That parasite causes obstruction. Can you see this lymphatic? Can you see the worms inside? Appreciate the cluster of worm. Appreciate the cluster of Wucheria bancrofti. It is obstructing the lymphatic. Since the lymphatic are present but they are obstructed, they are non-functional. Since they are non-functional, so person have edema of that leg, foot, lower limb. And this edema is known as elephantitis. Elephantitis because the leg is looking like an elephant leg. That's why the disease is known as elephantitis. The third reason of the lymphoedema is congenital or hereditary. Hereditary inside the child, all the lymphatics are defective and they are not taking the water. Such disease is known as Milroy disease. So these are the 3 examples of lymphoedema. Coming on the 4th reason of edema. The first was increased hydrostatic pressure, outward pressure. The second was decreased oncotic pressure, osmotic pressure, inward pressure. The third is lymphatic obstruction. For each of these mechanisms, I have given you examples. Now coming on the 4th type of edema, sodium water retention. Now what is sodium water retention? When the body does sodium water retention in 2 conditions, heart failure, cardiac failure and renal failure. Please understand. Imagine left heart failure. This left ventricle is not pumping properly. Left heart failure. So blood will not ejected in aorta or less blood will ejected in aorta. So all the organs of human body receive less blood. This is known as hypovolemia. So kidney is most sensitive organ. Whenever blood in the kidney is less, because the left ventricle is not pumping in heart failure, less blood is coming in aorta or no blood is coming in aorta, so kidney do not receive blood. So renal ischemia take place. So on renal ischemia, the kidney will stimulate, inside the kidney there are cells known as juxtaglomerular apparatus that will get stimulated and that will start secreting renin in the blood. Renin convert angiotensinogen into angiotensin 1. So in this diagram, you can see the renal ischemia. You can see the renal ischemia due to the left ventricle failure. Left ventricle is not contracting properly. So hypovolemia leads to renal ischemia. Because of renal ischemia, the JJ apparatus got stimulated and it is secreting renin. So renin converts angiotensinogen to angiotensin 1. Angiotensin 1 get converted to angiotensin 2 by another enzyme ACE. So this angiotensin 2 will cause aldosterone secretion and that will cause sodium water retention in the body that can lead to edema. So this is the mechanism how left heart failure can lead to edema. This is the first mechanism. The second mechanism, in renal failure also, the kidney is not functioning properly and kidney is causing sodium water retention. So there are 2 examples, heart failure and renal failure, because of which there is sodium water retention in human body and that can lead to edema, the 4th mechanism. The 5th and the last mechanism is increased permeability. What do you mean by increased permeability? So see this diagram, you will understand. You can see a blood vessel in the first diagram. Please concentrate on the endothelial cell lining. The endothelial cells are continuous with each other. There is no gap between the endothelial cells. There is no gap in the first diagram. So the fluid and the protein is not coming out. But see the second diagram. In the second diagram, please appreciate all the endothelial cells are retracting, they are contracting. So you can appreciate the gaps between them. Please appreciate the gaps between the endothelial cell. From these gaps, can you appreciate these are the proteins present inside the blood vessel. The protein along with fluid is coming out. Such edema in which fluid and abundant of protein and cells are also present, such edema is known as exudate type of edema, and this is exudate edema. So that is the fifth mechanism, that is increased permeability. In the increased permeability, the capillary endothelium is injured, so gaps are created in the endothelial cell. So between the endothelial cell, gaps are present, so leakage of protein and fluid takes place. From this gap, that can lead to edema, and this mechanism is known as increased vascular permeability. So what are the examples of this mechanism? It can be of two types, generalized edema and localized edema. Generalized edema is edema of throughout the body. It is known as anasarca. Anasarca. And localized edema is a focal edema at some point of the body. So the reasons for generalized edema can be systemic infection, poison, certain drugs, anaphylactic reaction, anorexia. These are the reasons of anasarca, that is generalized edema. Now coming on localized edema, the reason can be allergic, insect bite, some chemical. You can see the mosquito bite, insect bite. So these are the reasons for inflammation, or you can say increased vascular permeability. So we understood the 5 causes of edema along with their example. So what are the 5 causes of edema? It is increased hydrostatic pressure, that is outward pressure, decreased oncotic pressure, that is inward pressure, lymphatic obstruction, the backup is obstructed, sodium water retention, and increased vascular permeability. The 5 causes of the edema along with their examples you must know. It is very important topic for the exam. Now coming on the types of edema. Edema is of 2 types. What are the 2 types of edema? Transudate and exudate. Transudate is protein poor and cell poor edema. On the contrary, exudate is protein rich and cell rich edema. So you can understand the 2 types of edema in this diagram. In this diagram, you can see the first blood vessel. Can you appreciate a blood vessel? This is the first blood vessel. See the lining, the endothelial lining here. So endothelial lining here is continuous. It is a continuous lining. The endothelial lining is there. Now in the second diagram, please appreciate the endothelial lining is still continuous, but the pressure changes are there. Hydrostatic pressure, outward pressure is more, or oncotic pressure is less, or any one of them, or both of them occurring together. So only fluid is coming out. If you can appreciate, only fluid is coming out, endothelial lining is continuous. So such edema is transudate, in which only fluid is there, no protein, no cell, because the endothelial lining is continuous and it takes place because of the pressure changes, right? See the second diagram. In the second diagram, you can see all the endothelial cells are injured, they are contracting. So you can appreciate the gaps between them. From these gaps, the protein and fluid both will come out. So fluid along with protein will leak from the gap, because gaps are present, so protein will come out, albumin will come out, and cells will come out. So such a edema in which along with fluid, proteins and cells are present, it is known as exudate. So edema is of 2 types. What is the 2 types of edema? Transudate, it is only fluid. It is only edema, no protein, no cell. So protein poor, cell poor edema is transudate edema. On the contrary, protein rich, cell rich edema, it is known as exudate. So exudate is due to formation of gaps. That is 5th mechanism, increased vascular permeability. The remaining 4 reasons, that is increased hydrostatic pressure, decreased oncotic pressure, lymphatic obstruction, and sodium water retention, they lead to transudate. But the 5th mechanism, that is increased vascular permeability or inflammation, it leads to exudate. So exudate edema is the inflammatory edema, and transudate edema is due to the remaining pressure changes, it is known as non-inflammatory edema. So these are the other names given to them. Transudate is protein poor, cell poor, and it is non-inflammatory. On the contrary, exudate is protein rich, cell rich, and it is inflammatory. So that is the edema. Now please understand the differences between them. You can see the differences between them. You can see there is transudate, exudate, the 2 types of edema. As I have told you, transudate is due to pressure changes, right? And exudate is due to increased vascular permeability. So transudate edema is non-inflammatory and exudate edema is inflammatory. In transudate edema, the protein is low, and in exudate it is high. See the protein content in both of them. See, not only protein, the specific gravity of transudate is also low and exudate is also high. Right, not only this, the LDH enzyme of transudate is low and exudate is high, but the pH is opposite. pH of transudate is more and exudate is less. So it is opposite, it is in opposite direction, and the glucose content of transudate is same as that of plasma, but the glucose content of exudate is low because the bacteria present in the inflammatory fluid, you can learn like that the microbe is consuming the glucose. So here glucose is low. right? So here cells are also, if you see the cells, there are few cells in the transudate and more cells in the exudate. So let me tell you the differences between the two types of edema. What are the two types of edema? Transudate, exudate. So this is transudate edema, this is exudate edema. So please enumerate the differences between them based on following point. First, tell me the nature of the edema, whether it is inflammatory or non-inflammatory. Then tell me the protein content of each of them, the cell content of each of them, protein less or more and cell is less or more. Tell me the specific gravity of each of them. Tell me the LDH content of each of them. Tell me the pH of each of them. So among these points, based on these points, you have to differentiate the two type of edema, transudate and exudate. Transudate edema is non-inflammatory. Exudate edema is inflammatory. Protein content, cell content, specific gravity and LDH. All things are less in transudate in contrast to exudate, protein rich, cell rich. More specific gravity, more LDH. But pH is reverse. pH in transudate is more and pH in exudate is less. So these are the points you have to learn. It is a very, very, very important point, not only for theory exams of the pathology, but also for the practicals of pathology. So you have to learn the differences between transudate and exudate. It is something you must know topic, transudate and exudate, the differences between them. So there are some more important points in edema. Generalized edema throughout the body is known as anasarca. You can appreciate in the diagram. Now in cardiac edema, the cardiac edema, it is known as dependent edema. The cardiac edema, the cardiac failure edema, edema and heart failure, it is dependent edema. Dependent edema means when the person stands up, the edema will be in the feet and the legs. When the person lie down, the edema will be in the back. So the edema will be in the dependent position of the body. That is known as dependent edema, and it basically occurs in heart failure, congestive heart failure. In renal failure, that is nephrotic syndrome. In renal failure edema, the edema basically occurs in the loose matrix of the body. Loose matrix in the body, you can appreciate the edema below the eye. It is known as periorbital edema. It can occur in ankles and genitals also, wherever loose tissue is there. So what is the summary? What we have learned in this session? We have learned three things in this session. What is edema? What is the pathogenesis of edema? What are the types of edema? So what is edema? Edema is abnormal and excessive accumulation of fluid in the interstitial space. The interstitial space is the space between the cell, that is edema. That is the definition of edema. What is the pathogenesis of the edema? There are 5 types, 5 causes of edema. Either increase in hydrostatic pressure, that is outward pressure, or decrease in oncotic pressure, that is inward pressure, or lymphatic obstruction, the backup are obstructed. Then sodium water retention and increased capillary permeability. For each of them, I have enumerated the examples. You must quote the examples for each of them along with the diagrams. Now coming on the types of edema. There are 2 types of edema, transudate, exudate. In transudate, only edema is there, that is fluid is there. No protein, no cell. But in exudate, along with edema fluid, there is protein and there is cell because gaps are present. And from these gaps, proteins and cells will leak out. So protein poor, cell poor edema is transudate. On the contrary, protein rich, cell rich edema is exudate. The 2 types of edema you can understand. That's all about edema.